Registered nurses deliver care to patients by applying validated interventions. Nurses learn about evidence-based practice, which aids them in pinpointing care strategies that can help their patients. In recent decades, evidence-based practice, or EBP, has become a key component of exceptional patient care. Welcome to this video presentation of evidence-based practice. I am Rosnancy, Sinaga. Firstly, we need to define what is evidence-based practice. Evidence-based practice, or EBP, is an interdisciplinary methodology that is related to education and clinical practices. The concept is mostly used by healthcare professionals and medical experts. It is an instructional strategy that depends on experiments, observations, tests, and various result-oriented evidences instead of a plain hypothesis. Ideally, EBP is the combination of clinical expertise, patient preference, and the best available evidence. Sackett, Rosenberg, Gray, Haynes, and Richardson define evidence-based practice as the conscientious, explicit, and judicious use of current best evidence in making decisions. Another definition of EBP is a process that combines well-researched interventions with the following: clinical experience, ethics, patient or client preferences, and culture. This definition based on National Association of Social Workers. Integration of best research evidences, clinical expertise, and patient values and needs will promote high-quality and cost-effective patient care with good outcomes. Studies show that evidence-based practice leads to higher quality care, improved patient outcomes, reduced cost, and greater nurse satisfaction than traditional approaches to care. But nurses remain inconsistent in their implementation of evidence-based care. Evidence-based practice is synonymous or similar to other terms in use. First, evidence-based practices, evidence-based treatments, evidence-based interventions, or EBP is synonymous also with evidence-based care or evidence-informed interventions. Let's look in a brief the history of evidence-based practice. EBP has its roots in evidence-based medicine, also referred to as evidence-based healthcare. It was created in the 1980s and popularized in the early 1990s. Medical textbooks were unable to keep up with rapid changes in medicine and were frequently based on the interpretations of few people in a respective field. At the same time, the medical literature in journals was being produced in record numbers but was poorly organized. Included in the history of evidence-based practice are the factors influencing its use in other disciplines. The first factor is it's always been done this way. Health sciences and others realized many tests and treatments were based on experience or routine rather than empirical proof. The second is accountability. Numerous accrediting agencies, organizations, government, and the public want to see that resources are going towards what's shown to work. The third is the cost effectiveness. This is based on England's National Health Service and recently the health insurance. The last factor is multidisciplinary teams. Many problems or scenarios can improve their outcomes by having multidisciplinary teams work together, and some problems are too complex for a single discipline to address. Evidence-based practice is not always incorporated due to the barriers like practicality of implementing changes and cookie-cutter or cookbook approach to care. Evidence-based practice is used because of benefits such as improved patient, family and caregiver outcomes. EBP also can improve provider, for example, for a nurse, physician, and hospital outcome. EBP also leads to the gold standard or best treatments. Let's look in the evidence-based practice process. There are 6 steps for EBP process according to Melnick and Mazurek. Step 1 is cultivate a spirit of inquiry. In this step, we start asking the kinds of questions that lay the groundwork for EBP. For example, in patients with head injuries, how does supine positioning compared with elevating the head of back 30 degrees affect intracranial pressure? Another example is, in patients with supraventricular tachycardia, how does administering the beta blocker metoprolol compared with administering no medicine affect the frequency of tachycardic episodes? After the nurse cultivates a spirit of inquiry, then she might go to the other step. It is to define a question that needs to be answered. Inquiries in this format take into account patient population of interest, or P, intervention or area of interest, or I, comparison intervention or group, or C, O for outcome, and time, or T. This format, or PICOT format, provides an efficient framework for searching electronic databases, one designed to retrieve only those articles relevant to the clinical questions. Within this step, to define a question that needs to be answered, we can use the case scenario on rapid response team as an example. The way to frame a question about whether use of such teams will result in a positive outcome. That would be, in acute care hospitals as patient population, how does having a rapid response team as the intervention compare with not having a response team as the comparison affect the number of cardiac arrests as the outcome, and during a 3-month period as time. Within this step, to define a question that needs to be answered, we can use the case scenario on rapid response teams as an example. The way to frame a question about whether use of such teams will result in positive outcomes. That would be, in acute care hospitals, it is the patient population. How does having a rapid response team as the intervention compared with not having a response team as the comparison affect the number of cardiac arrests as the outcome, and during a 3-month period as time. So this is the example of how to use the PICOT format. After defining a question that needs to be answered, now we will go to step 2, acquiring the literature that will be analyzed, or building and executing the search. So in this step, we will search for the best evidence. For the PICOT questions on rapid response teams, the first key phrase to be entered into the database would be acute care hospitals. And the second term to be searched would be rapid response team, then followed by cardiac arrest, and the remaining terms in PICOT questions. Within step 2, to acquire the literature that will be analyzed, the last step of the search is to combine the results of the searches for each of the terms. This method will narrow the results to articles pertinent to the clinical question, often resulting in fewer than 20. It also helps to set limits on the final search. After acquiring the literature that will be analyzed, then we will go to another step, that is critical appraisal. We will critically appraise the evidence or from patient preferences. So in this step, once articles are selected for review, they must be rapidly appraised to determine which are most relevant, valid, reliable, and applicable to the clinical question. These studies are the keeper studies. One reason clinicians worry that they don't have time to implement EBP is that many have been taught a laborious critiquing process, including the use of numerous questions designed to reveal every element of a study. In this step to appraise the evidence, there are 3 important questions to evaluate the study's worth. The first question that we can use is, are the results of the study valid? This question of study validity centers on whether the research methods are rigorous enough to render findings as close to the truth as possible. For example, did the researchers randomly assign subjects to treatment or control groups and ensure that they shared key characteristics prior to treatment? Were valid and reliable instruments used to measure key outcomes? The second question is, what are the results and are they important? For intervention studies, this question of study reliability addresses whether the intervention worked, its impact on outcomes, and the likelihood of obtaining similar results in the clinician's own practice settings. In this step, to appraise the evidence, there are 3 important questions that we can use to evaluate a study's worth. The first question is, are the results of the study valid? This question of study validity centers on whether the research methods are rigorous enough to render findings as close to the truth as possible. For example, did the researchers randomly assign subjects to treatment or control groups and ensure that they shared key characteristics prior to treatment? Were valid and reliable instruments used to measure key outcomes? The second question that we can use to appraise the evidence is, what are the results and are they important? For intervention studies, this question of study reliability addresses whether the intervention worked, its impact on outcomes, and the likelihood of obtaining similar results in the clinician's own practice settings. For qualitative studies, this includes assessing whether the research approach fits the purpose of the study, along with evaluating other aspects of the research, such as whether the results can be confirmed. And the last question that we can use to appraise the evidence is, will the results help me care for my patients? This question of study applicability covers clinical consideration, such as whether subjects in the study are similar to one's own patients, whether benefits outweigh risk, feasibility and cost effectiveness, and patient values and preferences. After appraising each study, the next step is to synthesize the studies to determine if they come to similar conclusions, thus supporting an EBP decision or change. So in step 4, we are to integrate the evaluated evidence into practice. We know that research evidence alone is not sufficient to justify a change in practice. Clinical expertise based on patient assessments, laboratory data, and data from outcomes management programs, as well as patients' preferences and values, are important components of EBP. There is no magic formula for how to weigh each of these elements. Implementation of EBP is highly influenced by institutional and clinical variables. For example, let's say there is a strong body of evidence showing reduced incidence of depression in burn patients if they receive 8 sessions of cognitive behavioral therapy prior to hospital discharge. You want your patients to have this therapy, and so do they. But budget constraints at your hospital prevent hiring a therapist to offer the treatment. This resource deficit hinders implementation of EBP. Let us move to step 5 in EBP process to re-evaluate the process to assess its efficacy and improve it in the future. After implementing EBP, it is important to monitor and evaluate any changes in outcomes so that positive effects can be supported and negative ones remedied. Just because an intervention was effective in a rigorously controlled trial doesn't mean it will work exactly in the same way in the clinical setting. Monitoring the effect of an EBP change on healthcare quality and outcomes can help clinicians spot flaws in implementation and identify more precisely which patients are most likely to benefit. When results differ from those reported in the research literature, monitoring can help determine why. We will go to the last step of EBP process, that is step 6. It is to disseminate EBP results. Clinicians can achieve wonderful outcomes for their patients through EBP, but sometimes they often fail to share their experiences with colleagues and their own or other healthcare organizations. And this leads to needless duplication of effort and perpetuates clinical approaches that are not evidence-based. Among ways to disseminate successful initiatives are EBP rounds in the institution, presentations at local, regional, and national conferences, and reports in peer-reviewed journals, professional newsletters, and we can disseminate the results for publications for general audiences. So what are the sources for evidence-based practice, or EBP? The sources are from systematic reviews, from meta-analysis, integrative reviews, and from meta-synthesis. We will see in a brief these sources. So one source for EBP is from integrative reviews. What are integrative reviews? It is to identify, analyze, and synthesize results from independent quantitative or qualitative studies to determine current knowledge. Integrative reviews include multiple types of research designs and literature types. Integrative reviews are a complicated review but give breadth and depth to conclusions. The source for EBP is from systematic reviews. So what are systematic reviews? It is a narrowly focused synthesis of research findings from quantitative studies. Systematic reviews looks at studies of similar methodology, and these systematic reviews has same standards of clarity, rigor, and replication of primary research studies. Steps in conducting systematic reviews. The first step is to formulate purpose and identify scope. The second is to develop specific questions or hypotheses. The third step is to establish criteria for inclusion or exclusion of studies. And the fourth step is to conduct extensive literature search of all sources. So, another step in systematic review based on Melnick, Feinert, Overholt, and Whitemore studies, it is to develop questionnaire and contact authors to gather data. Then the next step is to critique studies for scientific merit and data analysis. Then we can analyze and interpret data. And the last step is to report the review. So another source for evidence-based practice is from meta-analysis. What is meta-analysis? It is statistically pools results from previous studies into single quantitative analysis, and this meta-analysis allows for application of scientific criteria, for example, sample size, level of significance, and variables. So, what results are reported in a meta-analysis? It will result in a large, diverse sample that is more representative of target population. Then there is determination of overall significance of probability of pooled data, and it also will result in indication of the efficacy of the intervention from the average effect size determined from several quality studies, and also there is strength of relationship between variables. What is the best evidence for use in practice? The first is the strength of the evidence is on the continuum from high quality results to lower quality results. And the best evidence is there is guidelines in developing evidence-based practice for nursing. The slide will present the strong versus weak evidence. The strongest evidence are meta-analysis, integrative reviews, and experimental studies, while the weaker evidence are descriptive surveys, qualitative studies, correlational studies, and quasi-experimental studies. We will look at models on how to use evidence-based in practice. The first model is Stadler model. Then the second is Iowa model of evidence-based practice. And the third model is Grove model. In Stadler model of research utilization, there are many phases. The first phase is preparation, then to validate, and the third phase is to compare, evaluation, or decision making. The fourth phase is the translation or the application, and the last phase is evaluation. Another model in EBP is the Iowa model of evidence-based practice. This model provides direction for development of evidence-based practice in agency. This model looks at triggers for change such as risk management data, financial data, organizational standards, and philosophy of care. So this is the Iowa model of evidence-based practice. In this model, the first step is we are going to identify the trigger where an EBP change is warranted. This can be either a knowledge-focused trigger or a problem-focused trigger. And the next step, we are going to determine if the problem at hand is a priority of the organization, practice, department, or unit. So if it is not a priority, then we'll consider the other triggers. So if it is the priority of the organization, then we'll go to another step. It is to form a team. In this team that we are going to develop, we are going to evaluate and implement the EBP change. This team should be made up of representatives both in and out of the nursing unit. This allows for interdisciplinary stakeholders in the team for better evaluation and implementation of the change. And then in the next step in this model, it is to gather or assemble and analyze the research related to the desired practice of change. So this includes formulating a good research question using the PICOT method and conducting a literature search looking for related research studies. The other step, it is to critique and synthesize the research discovered during the literature search. This includes reviewing the research to determine if the change is scientifically sound. So, if there is sufficient research base, then we will conduct the pilot study or pilot program. But if there is no sufficient research base, then we will determine if there is a need and resources available to conduct actual research study. If so, conduct the study, and then we'll go to the previous step. And if there is no sufficient research base, we can review and base practice on other types of evidence. For example, case reports, expert opinions, scientific principles and theory, and then we can move to the next step. it is to conduct the pilot program. And then in the next step, it is to implement change into a pilot program. So in this step, we do not conduct a full practice change, but rather change one or two smaller areas or units first for evaluation. And the last step in this model, it is to evaluate results. Is the change appropriate for adoption in practice? If the answer is no, then we will continue to evaluate the care and new research to be able to revisit the issue in the future with new information. And if the change appropriate for adoption in practice, then we will introduce the change across the department, unit, practice, or organization. And after the introduction of the change, we will continue to observe, to evaluate, and to analyze the results. As technology and research changes, this could be an issue that will once again need to be evaluated. So these are the examples of questions on how to apply the Iowa model. What are effective strategies for implementation? What are the outcomes from using the research findings? Do the data support the change? And is the proposed change an agency priority? So another model that we can use on how to implement the evidence-based practice is the growth model. These are the steps of this model. The first one is the nurses should identify the practice problem. Then they will search for the best research evidence to manage the problem in their practice. And then the next step is to note that an evidence-based guideline has been developed. Then the nurse will integrate the evidence-based guidelines with clinical expertise. Then the next step in this growth model, it is to use the evidence-based guideline in practice. Then the nurse will monitor outcomes from use of evidence-based guidelines. Then the nurses can make some refinements of the evidence-based guidelines. And the last step is to apply the evidence-based in practice. So this is the model of growth model. So if you see, this model is generally is almost the same with Iowa model. And the first step is the nurse should find the problem. Then she will search for the best evidence that will yield evidence-based guidelines. Then the nurses will or should have the quality guidelines. And then in the next step, the nurse will integrate the evidence-based guidelines with clinical expertise. Then she will use the evidence-based guidelines in the practice. Then after, she will monitor the outcomes from use of the evidence-based guidelines. Then she could make some refinements if needed. Then the evidence-based practice can be applied. There are many factors to consider when we are going to implement the evidence-based practice or change. The first factor is time, and support or resources needed. Another factor to consider is money, and another factor is institutional or other barriers. So when we look at the barriers at the administrative level, the general barrier is the lack of emphasis placed on research. Then other barrier is they have limited resources to make changes based on research. And other barrier, they can make changes but not based on research. So the barriers at the clinician or a nurse level is sometimes the nurse lack of knowledge of research process, and sometimes the nurses do not keep up to date with the research, and sometimes the nurses do not believe or they don't trust the research findings, and they don't have an ability to to implement findings into daily practice. So how to develop the guidelines for evidence-based practice? The Agency for Healthcare Research and Qualities will help with guidelines through development of an expert panel. Then this group will define the scope of the guidelines. Then they will synthesize the findings to develop recommendations for practice. Guidelines developed are presented at meetings and published. So these are the examples of the Agency for Healthcare Research and Quality Practice Guidelines. Pain management, TQBT prediction or prevention, cataract treatment in adults, and so forth. We come to the end of this video presentation about evidence-based practice. Nurses learn about evidence-based practice, which aids them in pinpointing care strategies that can help their patients. And EBP has become a key component of exceptional patient care. EBP is an integration of research evidence, clinical expertise, and a patient's preferences. This problem-solving approach to clinical practice encourages nurses to provide individualized patient care. EBP helps nurses to determine an effective course of action for care delivery. EBP process involves many steps. The first step is to form a clinical question to identify a problem, then to gather the best evidence, then to analyze the evidence, then the next step is to apply the evidence to clinical practice, and the last step is to assess the result or to evaluate the result. There are kinds of research used in EBP. They are systematic reviews, meta-analysis, integrative reviews, and meta-synthesis. The evidence-based practice will give benefit to nurses, patients, and to healthcare organizations as well. The inclusion of EBP in nursing provides nurses with the scientific research to make well-founded decisions. Through EBP, nurses can stay updated about new medical protocols for patient care by searching for documented interventions that fit the profiles of their patients. Nurses can increase their patients' chances for recovery. EBP enables nurses to evaluate research so they understand the risk or effectiveness of a diagnostic test or treatment. With the application of EBP comes better patient outcomes, which can decrease the demand for healthcare resources. Thus, healthcare organizations can reduce expenses. I hope you can learn from this presentation, and thank you for watching.